This is Dr. Janice Williams, and I will be lecturing on assessment of cardiovascular murmurs and give a brief introduction to EKG interpretation. As we go through this lecture, I would like to emphasize that this is just a brief introduction. I would also like to let you know that you will be getting more exposure to EKG interpretation as you go along in the program. So this is just to kind of remind those of you who have not been exposed to EKGs or murmurs recently, and for those of you who are well skilled in it, this should be a review. Let's begin by first defining what is a murmur. So it's a series of sounds that are produced by the turbulent flow of blood through at high velocity across an obstruction that results in an audible vibration. Again, so remember that a murmur, it is actually the turbulent flow. So it's the sound that is produced as a result of the turbulent flow at high velocity as a result of an obstruction. And because of that obstruction, we can hear an audible vibration. Oftentimes, murmurs, the way we differentiate them is based off of pathology. Some of these murmurs can be what we call benign. They can occur with age. And then some of them can actually be more serious and need further evaluation. So it is important to know when we are evaluating a murmur, we need to make sure that we are looking at certain factors. Those factors include where's the location. So remember in your cardiovascular assessment lecture, we talked about the 5 cardinal sites of where you listen to heart sounds. So the location is important, and it'll also often help facilitate you understanding what murmur it is. The intensity. Can you hear it with your stethoscope, without your stethoscope? Is it faint? Also the pitch. Does it sound high or is it soft? And does it radiate? Because remember, when you listen and perform a cardiovascular assessment, you should always listen in those 5 cardinal areas. So you want to know if you hear that murmur, does it radiate? Do you hear it in any other areas on the chest wall? And you also want to think about the timing. You should also remember from your cardiovascular lecture how important it is to understand when S1 and S2 occurs. So when you're listening and if you hear an abnormal sound or a murmur, then you want to be able to identify when do you hear that murmur. Do you hear it before the S1, after the S1, during any of those heart sounds? Because that's going to give us a good indication of what may be the cause of that murmur. Let me preference for you. Appreciating murmurs upon assessment is a skill that you keep practicing. It is not a skill that comes easy because not all murmurs are clear. So the more you listen to heart sounds, the more astute you will get with identifying murmurs. Later on in the slide, I have included some links to different sites that will assist you with just listening to the different types of heart murmurs. When we talk about some of the causes that can contribute to murmurs, we think about there could be partial obstructions within the cardiac system. There can be some irregularities of the valves. There can also be what we call regurgitation. So the blood flows through the valves into the next chamber. However, there is some regurgitation where some of that blood backs up into the chamber that it just came out of. And you can also see that there can be some shunting of blood because of the high pressure that occurs in some of the heart chambers. And we will, as we go through this, you will hopefully be able to begin to identify the differences in these murmurs. And there later on in the lecture, there is a chart that will help you. So If you identify a murmur, what is important for us as providers and as to how to document those murmurs? It is important when document a murmur to talk about the grade of that murmur. That's how intense it is. Where do you hear that murmur? Do you hear it at the second intercostal space, right sternal border? Do you hear it at the fifth intercostal space, midclavicular line? Or does it radiate? So when you're documenting, you need to ensure that you identify the location and if it radiates. And also you want to identify is the pitch high, medium, or low. If you remember from the cardiac lectures previously, when we talked about assessing the cardiac sounds, when you are listening, one of the things that it's important to do is use not only the diaphragm, but also the bell of your stethoscope. Some murmurs will be picked up better with the bell and some with the diaphragm. So let me give you some, the scale which we use to grade cardiac murmurs. The grading scale goes from 1 to 6, and you can read which each grade is. So a grade 1 murmur oftentimes is very faint and it's not heard in all positions. For some providers, it takes practice and consistent exposure to murmurs to be able to pick up a grade 1. You normally have to have a trained ear to pick up a grade 1 murmur. Grade 2 is a soft murmur, but you can hear it. A grade 3 is moderately loud. So when you are auscultating the cardiovascular system, it is a murmur that when you put your stethoscope on the patient's chest, you can hear that murmur without much focus. It's kind of like you put it there, you hear S1, S2, and you can also appreciate that murmur. A grade 4 is a very loud, and oftentimes you'll have that thrill. And remember, a thrill is when you can feel the vibration on the chest wall. Grade 5, it's very loud. Once you barely put your stethoscope on the chest, you can appreciate that murmur. And it also has a thrill. So the difference is between a 4 and a 5 is they both are loud. However, in a grade 5, you barely have your stethoscope on the patient's chest and you can appreciate it. Grade 6 can be heard oftentimes when you don't even have the stethoscope on their chest. For some of you who are, if you've ever worked in the cardiac wing or maybe in the ICU, then you may have appreciated some grade 6. Now let's just talk about what you may hear and how to begin to identify murmurs according to their location. If you remember from the cardiovascular lecture, when you're listening and your 5 cardinal areas on the chest wall, if you're listening on the second intercostal space, right sternal border, that's when you hear the aorta. So think about murmurs that may be present in that area. These are murmurs that may deal with the aorta. So you're thinking about your aortic stenosis and aortic vascular stenosis as well. These are also murmurs that when you're listening will be what we call systolic. So think about what the valves are doing in the aorta, the aortic valve, during systole. And then as you look through the slide, you can see that I have outlined for you every location on the cardinal signs of what type of murmur. And this is not comprehensive. This is just to kind of help you understand how to think about assessing murmurs. If you go to the second intercostal space, left sternal border, you can see that may be where you may hear either diastolic or systolic. Remember we talked about radiation of murmurs, and then you have to think about locations because depending the aortic Your second intercostal space, right sternal border, second intercostal space, left sternal border are very close in diameter. Thus, those murmurs may appreciate and radiate to the other side. And if you're listening at the fifth intercostal space, midclavicular line, this is where you may have your diastolic or hollow systolic murmurs, such as mitral regurgitation, mitral stenosis. Think about the vowels that you can appreciate. This is also where, if you think about how you perform the cardiovascular exam, this is when you may have the patient on their left, laying in the left lateral decubitus position. So it kind of shifts the heart a little bit and allows you to hear better. So what valves would you hear there? What sounds could you appreciate? So it's very important that you're able to think about the structures that underlie the area in which you're listening when it comes to identifying murmurs. I have included here for you a slide that talks that will explain to you the different murmurs that you may appreciate. And what it does is this slide will tell you not only the murmur, but where that murmur may be located, what you may find on your physical exam, what you may see on your EKG and on your chest x-rays. This is not for you to memorize. This is just a resource for you. So as you start to see patients and as you are studying, it kind of helps you to be able to learn and, in a sense, memorize what murmurs may be appreciated when you're listening to your patient's heart. This will be helpful because as a practitioner, we can't remember everything. However, if we start to practice and memorize some of the most common murmurs that may be appreciated and what their characteristics and what makes them distinct from other murmurs, it will begin to help you when you're starting to see your patients to increase your ability to have differentials and think about some of the other symptoms your patients may be experiencing. Also included here is a slide on diastolic murmurs, talking about those same characteristics as well. I have also included on this slide a video that explains some of the basic heart sounds that providers may be exposed to. When you listen to this video, what would be helpful is make sure that you put on your headphones and spend time just trying to listen to the lecturer at the time and hear the heart sounds and picture it in your mind as you think about the conduction system of the cardiovascular system. Now I would like to kind of transfer a little bit and just talk about the normal conduction system of the heart. Because what I'm going to do now is we're going to briefly talk about EKGs. So we talked about murmurs. Now I just would like to introduce you to EKGs. But before we do that, this should be a review for you because you've taken anatomy and physiology and you are all nurses. But I wanted to just highlight some things that you think about when you're going to interpret an EKG. First, our conduction system of the heart starts in the SA node. It then travels from the SA node to the atrioventricular node, from the atrioventricular node to the bundle of His, and then it goes to the bundle branches and then the Purkinje fibers, right? So we know that SA node sits in the right atrium, and that is usually what we call our pacemaker. Our heartbeats is normally between 60 to 100 beats per minute. And as it travels to the AV node or the atrioventricular node, that heart rate, that pacemaker now is from no longer 60 to 100 beats a minute, but in the AV node is 40 to 60 beats a minute. And this delay allows the atrial contraction to occur. And then it then travels to the bundle of His, which is along the ventricles. And now our heartbeat, our beats per minute is 20 to 40. Because what happens is as it goes through the bundle of His, it has to contract the ventricles. And think about the ventricles are a larger muscle, and the contraction is under higher pressure. And so now we have our beats per minute at 20 to 40. And then after it goes from the bundle of His, it goes to the right and the left bundle branches. And the electrical impulse is transmitted to the right and left ventricles. And then it continues and ends in the Purkinje fibers, and it gives the quick impulse. So that is just the normal process of the conduction system. When you're thinking, before we talk about EKGs, think about, we just explained murmurs. If any part of the conduction system has any structural changes, or if the heart has any functional changes, any obstructions, how that can change how blood flows through the heart, thus contributing to murmurs as well. Also, if there's any change or any obstructions, how that can lead to EKG changes. What I hope that you hear from me is how you connect the pathology and the anatomy to what we may present to you as a practitioner. On this slide, we just previously talked about the conduction system. What I wanted to do is give you an example of how that conduction system looks and translates to an EKG. So when you're looking at an EKG test strip, we all should remember that we're looking at the PQRS on the EKG, right? So when we're doing that, that is reflective of what is going on in this conduction system, but it's transmitted through an EKG. So if you look at the slides, it tells you about the polarization and depolarization that occurs as you're looking at your EKG. This is important to know. So when you see abnormalities on your EKG, it will help you to identify what part of the heart may be having a change or some type of pathology. And you can read this from the slide at where the SA node depolarizes, which is right before that P wave. And then you get the impulse that arrives to the AV node. In a sense, it's in the middle of that P wave. And then the impulse passes to the bundle of His, which is at the end of the P wave. And then it goes to the bundle branches and the Purkinje fibers. And so think about the heart and how it impacts that process. And if anything pathological is shown on an EKG, you're thinking also about what part of the conduction system may be impacted, as well as are there any structural changes in that area that may be occurring. So now let's just give you a brief overview about what is a 12-lead EKG. So you can see here from the slide that a 12-lead EKG, it looks at the heart from 12 different leads. Each lead takes a different view of the heart, and it looks at the two electrodes from opposite polarity. And then we always have one of those electrodes will be our referencing point. It is important to know we're talking about a 12 lead, but in a 12 lead, you have 6 limb leads and 6 precordial leads. And this picture just shows you how, when you're looking at how the EKG, a 12 lead reads, we have a frontal plane and a transverse. And please remember, this is just an introduction. You will have modules on EKGs. I just want you to kind of get an understanding of how an EKG, how to interpret the information that you're seeing. So the EKG is like taking a picture from different angles. This should be all review for everyone. This is just to highlight again and remind you of where EKG leads are placed. This should be a reminder. Now let's talk a little bit about what an EKG, what the waveform actually is. So when we're looking at an EKG, if you remember, and this should be review for many of you, the P wave is our atrial depolarization. The PR interval is the time from onset of atrial activation to the onset of ventricle activation. So think about the PR interval. Onset of atrial activation to the onset of ventricular activation. So when you're looking at this EKG test strip, think about the very beginning of the P wave to the end of the P wave, right before you get that inverted dip of the QRS. That is our PR interval. That PR interval should range between 0.12 to 0.20. Many of you probably remember that. Then our QRS, which is our ventricular depolarization, usually is that first downward deflection, and then it goes up when we talk about QRS to our downward deflection of the R wave. That is our QRS. That range should be less than 0.12 seconds. And then our QT interval, which is the ventricular activation and recovery. So that begins at the QRS. So we begin at the Q and it ends at the T wave. That range should be 0.36 to 0.44. And I want you just to think about if the range is less than when you're measuring, if that range comes out to be less than the normal range or longer than the normal range, then you start to think what conditions, what may be going on to cause either the acceleration or the extension. Then we also have the ST to T wave, which is the ventricular repolarization, right? Because we need the ventricles to repolarize. And that ST, we call that the ST segment. Sometimes, not often, you may see a U wave. And what that is, that may be a small deflection that is seen just after the T wave. And it represents the repolarization of papillaries, M and P fibers. You don't always see that. If you don't see it, it's not an issue. But if you ever see that wave, then just know that that's what that is reflective of. So it is important when we're doing an EKG to be able to first identify and understand what this electrical pathway, what these waves reflect. The P wave is usually looking at the atrial depolarization. The QRS is ventricular depolarization. The QT is the time for repolarization. And then sometimes you can get your ST and your U waves. I've included this just for your knowledge so you can, when you think about reading a 12 lead, and many of you have probably seen one before, when you're looking at the 12 lead EKG, it is important to know which part of the heart the leads are taking a picture of. So this is just a document for you here, or a picture of a 12 lead that identifies those areas for you. This is something you kind of remember and memorize until you can picture it in your mind of where these leads are placed on the patient's chest. And as we talked about the ranges for the P wave, the QRS, this slide just highlights for you how do you come up with those numbers? How do you know if it's a 0.12? One of the simplest ways to begin for those of you who may not be comfortable with EKGs is looking at the horizontal squares talks about the time, where the vertical squares talk about the amplitude. Okay? Horizontal is time, vertical is amplitude. And so what I want you to see is on this slide, it breaks down the EKGs paper for you so you can understand, how do we get the time? How do we understand the amplitude? So if you count 1, 2, 3, 4, 5 blocks, that's 0.20 seconds. And what you're going to do is, when you're looking at calculating the different, and remember we talked about the different processes of the conduction system, it is those blocks that you will count to come up with your time and your range. And then if you want to look at amplitude, then what you will do is you will look at the vertical aspect, and that is done in millivolts. Highlighted on this chart for you. So if you're trying to measure the PR, so you will measure the PR from the beginning of the P wave to the beginning of the QRS. And then you will do the QRS from the downward deflection of the Q to the downward deflection of the R. And if you want the QT, from the beginning of the Q to the beginning of the T. And if you want to measure the ST, it'll be from the beginning of the S to the beginning of the T. So you see how that works? And you should be able to see that on the bottom left-hand side of your PowerPoint presentation. And I've added this in just so that you can, when we talk about the heart sounds, you should be able to click on this slide and be able to hear these heart sounds and get a better understanding of how the heart sounds, the S1, the S2, how they correlate with what you see on the EKG. So what are some of the abnormalities? What are some of the readings? What are that you will be doing when you're reading your EKG? Some of those conduction abnormalities that we see. So we got sinus bradycardia, we get sinus tachycardia, you get atrial fibrillation and flutter, and then you can definitely get asystole. So we'll talk a little bit more about that. I'm going to give you some steps that I utilize when I am trying to read and interpret an EKG. One of the, if you don't remember anything else from this lecture, please remember, when you go to interpret and read an EKG, be systematic in your reading process every time. No matter what that EKG looks like, go through the same steps every time to interpret that EKG. This way you don't miss anything. So the steps I would tell you is, first, is the EKG rhythm regular or irregular? And you can march that out by looking at the QRS. And you literally march it out and see if they're the same distance. I usually just take a piece of paper, I mark that piece of paper like a ruler, and I march out, are the Q waves the same distance every time? Next, you want to identify and examine the P waves. Are they present? If they're present, are they upright? Okay, because you got to think about the angle in which you're taking the picture with the EKG. Your P wave should be upright. If they're not upright, why are they not upright? You just may be considering that, but that's what you're looking at. And then you want to measure that PR interval. And remember, the range is between 0.12 to 0.20 seconds. After you do that, you've looked at your P wave and you've measured it, you then want to go to measuring your QRS complex. And if you remember, the QRS complex, what? Starts at the beginning of the Q, ends at the downward deflection of the S. That should be 0.6 to 0.12. And then you want to determine, is the rhythm regular or irregular? As you march those Q waves out, can you march them out at the same distance, or are they not occurring at the same rate every time? Then you want to determine, what is the heart rate? In most 12-lead EKGs, there will be a heart rate given to you. However, you can calculate your own heart rate. And I've written in here how you can calculate it according to 6-second method, which means you count your R waves, okay? And then you multiply it down times 10. This is good if you have an irregular rate. That means your QRSs are not marching out consistently. Or what you can do is you can divide 300 by the number of big boxes between two R's. And that's with a regular rhythm. If you do that, you can come up with your heart rate. And then what you want to try to do is identify that rhythm. Okay? So let's look at this. In this EKG, is the rhythm regular? What you want to know is, do they march out? Do these QRSs march out? Are they same distance? If they are, then that's regular. Then you want to try to identify your P waves. Do you have P waves? Do you have a P wave before every QRS? If so, you then want to measure your P wave or your PR interval. Then you want to measure your QRS complexes. And then you want to try to determine the rhythm. Is it regular or irregular? And then you want to calculate your heart rate if you can. And then you identify this rhythm. And this one is normal sinus rhythm. I have included multiple test strips here for you. And I've outlined at the bottom the same process every time. So you can take some time and try to see if you can calculate these EKG test strips. If not, know that you're going to get more exposure to this. This is just an introduction, and this is just the process that I utilize. You can utilize the process that works best for you. There are many videos on this. For some of you, you may have been exposed to EKG reading and you're very fluent in it. So if you have a process that works for you, great, continue to use that process. And so as you see here, we got sinus tachycardia, ventricular tachycardia. And as you start to look at these test strips, even if you're not sure what you're evaluating, you can definitely see that there are some differences. And then so if you go through this process, you may be able to identify these common conduction abnormalities. One thing I would like to say about atrial flutter, if you look at it, we often will refer this to as sawtooth as well. When we're documenting atrial flutter, also oftentimes we will say atrial flutter with 2 to 1 or 3 to 1. And what you're doing is you're trying to show how many of these PR intervals, in a sense, do you have between each QRS. So if you look at your strips starting at the left, and you see your QRS, and then you see 1, 2, 3, right? 1, 2, 3. You see 3 between each QRS after you have your repolarization. And what that does is that tells you that's the conduction. So you get a little, and that's where we get that atrial flutter 3 to 1, atrial flutter 4 to 1. And then this is atrial fibrillation. Sometimes atrial fibrillation can get confusing with atrial flutter, but just some things to think about for those of you who are not have not had to consistently look at EKGs. Atrial flutter is more like a quivering of the heart. So it's like when you look at the PR intervals, what they do is they more look like a wave pool, like in the sea. Whereas atrial flutter, not always, but oftentimes will be more of sawtooth, looking like shark's teeth, where flutter is more as just a quivering. The reason atrial flutter is very concerning, because think about the atriums they don't have a hard, consistent contraction. What they're doing is they're just like quivering, kind of like when you get cold, when your mouth quivers. So if it's quivering, then blood can get stagnant and it can lead to increased risk of passing blood clots. So it is something that definitely has to be taken care of. And I concluded with asystole, which many of us have probably seen before if we've practiced. It's basically, in layman's terms, or medical terms, we also call it flatlining. There's nothing really identifiable about this strip. So that's just a brief introduction related to EKG interpretations. You will definitely get a lot more and more detailed and more time to practice. This is not something that we are expecting you to have a full knowledge of in this course. What I would like you just to be able to understand is, what is the conduction system? How does the conduction system work in the cardiovascular? But this is just to help you as you move forward to build on.